when I checked the literature, I saw two main groups. I didn't see so many papers about these two issues, varization or valgization osteotomy at adults or
Yep.
femoral derotation osteotomy. One main group is you. I saw many papers from you, 2009 Clinical Orthopedics AOS paper. And at your papers, you said our indications for derotational osteotomy, gait dysfunction, ROM deficiencies, or instability after periacetabullar osteotomy. At your core paper, you mentioned that you routinely do intraoperative arthrotomy to your periacetabullar osteotomy patients, and you check whether there is impingement or dysplasia. You check dysplasia at several degrees of flexion. For example, 10 degrees of extension. You check this instability, 45 degrees of flexion and 90 degrees of flexion. But a second group is Bern group, Switzerland group. They say, interestingly, there are 6 main groups of different degrees of version at hip preservation patients. And mainly, CAM patients have tendency to have lower femoral version. And dysplasia patients, especially severe dysplasia patients, tend to have increased femoral version. So there are some controversial issues. I will ask later at the end of topic. For example, which method is more correct? There can be up to 10 degrees of difference in measurement techniques. And what is lower value? What is upper value for femoral version? For example, Dr. Martins tells his patients had previous hip scope failure or lumbar surgery failure. And he tells at younger patients, I try to do proximal femoral osteotomy, then if needed, additional hip scope. Is it the same for you? And he mentions his failure patients most of the time has concomitant dysplasia. And his, for example, upper value for femoral version and lower value is different. So we try to learn from your extensive expertise, and I hope it will be very useful for all orthopedic surgeons in Turkey. Thank you so much again, Dr. Clohisy.
Sure. Well, thanks for that summary of things. You're ready for me to go into the talk?
Hocam,
Yeah, sure.
hocam başlıyor muyuz? Hocam
Yes.
hocam başlıyorsa haber vereceğim ben size. Sunum açacak mı? Sunum var mı? Çünkü yayına vereceğim. Ben yayına vermedim. Şimdi yayına vereceğim. Vereyim mi yayına?
Ver.
Hocam hazır diye başlıyorum. Bir saniye. Hazır. 3, 2, 1 yayındayız. Hocam buyurun başlayın. Onur hocam.
Can you see this? Can you see my talk?
Yes, I can see your talk and your presentation.
Okay.
So can I do the summary again, Hakan, or I am giving talk to Professor Clohisy directly?
Yes.
Oh,
Please.
okay, Professor Clohisy. Please, it's your turn. Thank you so much. I will ask at the end again.
Okay. So I'm going to talk about proximal femoral osteotomy. Dr. Hapa has asked me to address that. I thought the best thing to do would be keep it pretty simple and just talk about our indications in a general sense. And then I'm going to go present some cases just to show examples of when we would use a proximal femoral osteotomy in our practice. And in general, over the past 10 years, I think we probably utilize proximal femoral osteotomy more than we did 10 years ago. We think it's an important part of hip preservation surgery. It's still in the minority as a procedure, but I think it's very important to complete the spectrum of procedures that we use for these patients. So proximal femoral and rotational deformities are increasingly recognized as contributors to pre-arthritic hip disease. We get a CT scan and look at femoral version really in all of our patients. Detailed understanding of the femoral anatomy and its contribution to patient symptoms and pathomechanics of the joint is important for making an accurate diagnosis and developing a successful treatment strategy. So the femoral osteotomies, as I mentioned, are an important aspect of our hip preservation treatment. And I think we think about them more now than we did 5-10 years ago. And again, an important part of the care for these patients. So in this talk, I'm going to just generally review the indications and basic techniques of femoral osteotomy that we use. There are different techniques. I'll show you my preferred techniques and do this by just presenting case examples so you understand how these concepts are used in clinical practice. So in general, these are the conditions where we think about proximal femoral osteotomy. And you mentioned the first two, and those are certainly the majority of the cases. And that is patients with hip dysplasia that have excessive femoral anteversion or coxa-valga as part of their dysplasia. Those aren't treated unless they're severe deformities. And then in the FAI patient, when they have relative or true retroversion of the femur, we include the derotation of the femur in some of those cases. Again, those tend to be extreme hip impingement cases. The other indications here are less common. So post-traumatic deformities, residual leg Kaposi disease, residual slips, we certainly see those. And proximal femoral osteotomy can be very effective in managing those cases. Let's see. This was the start of the talk. I'm just indicating that these deformities play a role in pre-arthritic hip disease. You need to understand them. They're an important part of our treatment. I'm going to review general indications, go over basic technique, and present case examples. These are the indications that I touched on. Osteonecrosis is really not indication in our practice, but worldwide, certainly there are surgeons that use proximal femoral osteotomy for osteonecrosis of the femoral head. So those are just general cases where we think about proximal femoral osteotomy. This is a case example. So this is a 15-year-old female. She has mild acetabular dysplasia. She has left hip pain. She has locking and catching mechanical symptoms. Lateral center edge angle is 19. Anterior inclination is 13. This is a hip I treated several years ago, probably 15 years ago. And honestly, today my treatment might be a little different, but that's the patient. My slide is not advancing. There we go. Sorry, guys. This is so on the left, you can see she has a hypertrophic labrum. She has increased signal intensity in the labrum and concern for a labral tear. Her CT scan diagnosed version was 48 degrees of anteversion. So in terms of treating this patient, we were considering a PAO and or a PFO, as well as a hip scope. So she's got mild acetabular dysplasia, coxa-valga, excessive femoral anteversion, and a labral tear. I decided to treat her with a scope and a femoral osteotomy because I thought her more severe disease was on the femoral side. I didn't think she needed both the acetabulum and the femur corrected. So our plan is to scope the hip and then do a proximal femoral varus derotation osteotomy. Here she is at the time of the osteotomy. So we did the scope, we repaired the labrum. She had an anterior labral tear. We're in the lateral position. The head is on your right, the foot is on your left. This is our lateral approach to the femur. You see the vastus lateralis top left. We incise the fascia posteriorly. We reflect the vastus anteriorly to gain access to the femur. On the top right, you see our guide pins, which are placed to mark our osteotomy line, as well as our blade plate insertion angle and to guide our correction. So those pins are placed in about 25 degrees of rotation to guide our rotation. And then you can see on the bottom our fluoroscopic images of the osteotomy at the superior aspect of the lesser trochanter, and then our chisel path on your left, and then placement of chisel on the right. So I'm using a blade plate for this osteotomy. That's what I usually use if I need to do a varus or valgus correction. If I do just derotation, then I use a large fragment compression plate. So here we are at placement of the chisel. And then, so we're going to place the chisel. That's going to guide our correction. We then make our osteotomy, make sure the osteotomy is complete and the edges of the osteotomy are smooth. And then we can do our reduction, our blade plate insertion, and then reduction of the distal fragment to the proximal fragment. So here we are in terms of placing the blade plate in the proximal fragment. So we've removed the chisel, placed the blade plate, and then fix that proximally, and then reduce the femur to the proximal, reduce the distal femur to the proximal fragment with the blade plate that dictates our correction under compression mode. So here we are post-op. So you see, can you see my cursor?
Yes.
Yeah, so she has a anterior labral detachment that was treated with 2 sutures just to stabilize that part of the labrum. She has a very nice, healthy joint. And then here's our osteotomy correction, about 10 degrees of varus. We did a 25-degree rotation correction and fixation with the blade plate. So she has had an excellent result. This is she went back to her sport activity. I actually saw her recently at 15 years, and she is asymptomatic. So she's done excellent with this correction on the femoral side. In general, I tend to correct the acetabular side unless the femur is just the more profound problem, which I thought it was in this case. So that's a case example where we have a little mild coxavalga, excessive femoral anteversion, and we're doing a varus derotation correction. And again, for me, I use a blade plate for that. Locking plates are becoming more popular, but I just like the control of the reduction and the fixation and the healing with a blade plate.
Excuse me, Dr. Clohisy.
Yeah.
You said
Yeah.
you will treat it differently if she came this year, recently. What will you do if she came, for example, 1 week ago, this same patient? You said I would treat it differently if she
I would say I might treat it differently. Let me see her. Yeah, with her, I would consider, I do, if we have both sides of the joint involved in the dysplasia, I certainly favor the PAO
first PO, yeah.
first. So in a patient like this, today I would think more about doing a PAO, but her femoral version is so high, I probably would still do what I did 15 years ago.
Okay, I understand wrong. Sorry. So
Okay.
you're interrupting, yeah, sorry.
No problem. Yeah, but feel free to interrupt. Okay, so that's her. So this is a little different problem. This 13-year-old female has more of an isolated rotational problem. Okay, so less of a valgus issue, but excessive femoral anteversion. So she has groin pain with activity in sports, range of motion, 105 of flexion, IRF is 70, ERF 30, so she's not balanced in terms of her introtation and flexion. Abduction 45, she has excellent motion, otherwise positive impingement, positive apprehension tests. So in this patient, I'm thinking that again, the acetabular morphology is good. She has signs and symptoms of instability. She has excessive femoral anteversion. So my diagnosis is excessive femoral anteversion with instability. And we're thinking about a isolated derotation of the femur. Her MRI also showed a labral tear, so she also had a hip arthroscopy in combination with the femoral procedure. So here she is at the time of the scope. You see the unstable labrum anteriorly with a labral flap overhanging into the joint. She also has debonding of the articular cartilage there adjacent to the labrum. So she has a bit of a sleeve, labral chondral sleeve. This is after our repair of that anterior labrum. So we do the anterior labrum, and the way we do that on the radiolucent table. We just treat the central compartment, and then we proceed with the femoral osteotomy. So here we are at surgery. You can see the imbalance with excessive intrarotation compared to external rotation. Here we are, we're marking our osteotomy line. We have the pins to control our derotation. Again, we make sure the osteotomy is complete. The edges are smooth so we can just rotate the bones. I usually, nowadays, in a case like this, I usually make the osteotomy higher now. I'll tend to make it just at the inferior aspect of the lesser trochanter. So the plate will go up on the trochanter a bit. I fix the plate proximally with 3 screws. I then loosen the screws, make the osteotomy cut, make the correction, or make the osteotomy cut, fix the plate proximally with the screws, and then reduce the distal fragment and fix it distally with compression. So that's how I do it if I just do derotation. Intramedullary nails are popular for osteotomy surgery, derotations. I've never really done that. I don't like to go through the abductors with the nail for the osteotomy. I do like to take all the hardware out after the osteotomy, so that would be another surgery through the abductors. So I prefer just to use a short, large frag compression plate, and also have noted great healing with that plate. So that's my approach to the simple derotation. And that can be in isolation or in combination with a PAO. Next case is a little more complicated. This is a 14-year-old male. He has a history of a right femoral neck fracture that was treated with screw reduction and screw fixation. That was 2 years prior. He's had the hardware removed. He has severe pain. He is unable to bear his full weight on the leg. He uses crutches for ambulation. So he's full-time on crutches, otherwise young, healthy, very disabled by this hip. So pretty diseased hip. We're concerned about the collapse of the femoral head. We're concerned about the extrusion of the femoral head, as that can create impingement. When we look at the lateral view, you know, there's a hint that maybe there's some healthier femoral head, posterior and medial, that could perhaps be used to be repositioned to make this a more functional hip. Here are some more imaging studies. So you see the AP X-ray. This is the MRI, or the CT scan, which shows relatively healthy posterior medial femoral head. And then the MR, you know, shows a lot of edema and whatnot. But again, it looks like the medial head is reasonable. So our plan with this patient, because of he's being so young, was to try to salvage this hip. So we're going to do a surgical hip dislocation, do a reshaping of the femoral head and recontouring of the neck, and then a flexion valgus proximal femoral osteotomy to bring the more posterior medial femoral head superiorly so it can be more of the weight-bearing surface. So that's the strategy with this very, very diseased femoral head. So here he is. He's 5 years out at this point. He's asymptomatic. He has a nice gait. He actually went back to playing basketball against my advice. But you can see how we've recontoured the head. We've done valgus flexion to take the more posterior medial femoral head and bring it superiorly. That was done through surgical dislocation. So we've done a trochanteric osteotomy. done the work in the joint, did the osteotomy correction, and then reattached the greater trochanter with small frag screws. So that's a more complex osteonecrosis post-traumatic problem, but very powerful solution combining the surgical dislocation with the femoral osteotomy. Okay, this is I think our last case. This is a 14-year-old competitive swimmer. She has worsening pain over the past year. She has a history of Perthes disease. That was treated with a proximal femoral varus osteotomy at age 8. She has a left-sided limp. She has a positive Trendelenburg. She's clinically short on that side, and her range of motion there flexes to 100, very restricted IRF and ERF of 15 degrees and 10 degrees on that side, limited abduction of 15. So pretty restricted range of motion, certainly in flexion. So these are her radiographs. So complicated hip. We've got a aspheric coxa magna, coxa breva, relatively high trochanter. Her proximal femur is in varus. We have this aspheric femoral head with overhang anteriorly, and we have secondary acetabular dysplasia. Our diagnosis in this hip is combined impingement and instability. So she has, our thought would be she has intra-articular impingement from the large aspheric femoral head. She likely has extra-articular impingement from the trochanter anteriorly here. Most of these Perthes hips have extra-articular impingement, also on the low neck. And then she has the acetabular dysplasia, which may contribute to instability of the hip. Here you see on the 3D CT scan the large head, the large anterior overhang of the femoral head, the deficiency of the acetabulum. Okay, so diagnosis in these Perthes hips, we're trying to figure out, are they unstable? Do they have FAI? Is it intra-articular FAI? Is it extra-articular FAI? And what type of treatments does the patient need? So what we tend to do, and it's hard to determine, especially the instability with our imaging. Physical exam helps, but we have found that intraoperative assessment of the hip is really what makes our final decision. So in general, what we do is we treat the femur with a surgical dislocation, and we correct the central compartment issues, the labrum, the articular cartilage, the femoral head cartilage. We do a femoral head reshaping, relative neck lengthening. So we take care of everything on the femoral side, and then we examine the hip and determine whether or not it's unstable. If the hip is subluxing through just a functional range of motion, then we go ahead with the PAO. We also need to make sure we have adequate range of motion for the PAO, so they need to have at least 90, if not 95 of flexion. They need to have 15 of abduction just to accommodate the PAO. So in a Perthes hip, we do the femoral reconstruction, assess the hip. If we think it's unstable, move forward with the PAO after the femoral reconstruction. So this patient, we did the surgical dislocation, head neck osteoplasty. We did a proximal femoral valgus osteotomy. In the joint, we repaired the labrum. We did a relative neck lengthening and troch advancement. Before fixing the troch, we assess the hip. We look at range of motion, stability, and congruency. And we thought the patient needed a PAO, so we proceeded with the PAO. So here she is 4 months after surgery. So we've started on the femoral side. We've done the head reshaping. We've done the recontouring or thinning of the neck. We then did the proximal femoral valgus osteotomy. and then refix the greater trochanter. Prior to refixing the greater trochanter, we assessed the hip, thought it was unstable. Most of these hips are unstable, more posterior superior. They slide out, or posterior lateral. They kind of slide out posterior lateral inflection. That's usually what provokes us to do the PAO. The PAO correction in the Perthes hip is not as aggressive as in classic acetabular dysplasia. Even though we reshape the head, we know the head is aspheric. It still tends to be large. So we don't want to overcorrect the socket and create secondary impingement. So we're a little less aggressive with the PAO correction in the Perthes hip. So this girl, she returned to her swimming. She saw her, let's see, I recently saw her at about 10 years after surgery. She's doing very well. You can see the correction on the right side, well-preserved joint space, improved head shape, certainly improved trochanteric impingement, improved neck shaft angle, and then stabilization with the PAO. So this combination, and we've published on this combination of procedures, is it's a big surgery, but it's certainly effective for the young patient, usually less than 25, with a well-preserved joint and a Perthes-like deformity of the hip. Okay, so those are just case examples of when we would use femoral osteotomy in terms of evaluating these patients. For hip preservation surgery, my patients get an MRI. They all get a CT scan. We do look at the femoral version, so we have cuts through the knee with the CT scan, and that help guides our treatment. So more and more, we're recognizing these deformities as contributors to prearthritic hip disease. Important to understand the femoral anatomy. That's going to help with the diagnosis as well as treatment decision-making. Preoperative planning and precise surgical technique, obviously very important. I can't overemphasize the pre-op planning in terms of whether or not you're going to do a femoral osteotomy. If you are going to do a femoral osteotomy, what are the details of that osteotomy? I think a real important point about the femoral osteotomy is to err on the side of undercorrecting. You don't necessarily have to create normal values, and you don't have to completely correct the deformity. I think the hip tolerates the deformity, or excuse me, the correction better when it's slightly undercorrected. So I err on the side of undercorrection. So in these patients with good patient selection and planning and surgical technique, they can really do outstanding. So again, most commonly we use it in dysplasia with or without periacetabular osteotomy. And then in the last 10 years, have begun to use it more for severe FAI that has not only head neck offset cam deformity, but has relative retroversion or true retroversion. So when a patient gets down to the 5 degrees of anteversion or below, we're starting to think about whether they need a femoral osteotomy or not. The other thing we've learned is version in the dysplastic hip it's very interesting in that when you look at dysplastic hips, about 50% of them have normal version. So at least in our patient population, about half have normal version. And then 35% have excessive anteversion. So in those hips, we're considering femoral osteotomy, but in the vast majority of cases, we don't do a femoral osteotomy. When the femoral version gets above 35 in the dysplastic hip, then we start to think more seriously about doing a femoral osteotomy. The other thing about the dysplastic patients is about 15% have relative retroversion or true retroversion. So those patients are at risk for secondary impingement after the PAO. So when they have retroversion on the femoral side, we definitely do an arthrotomy. We definitely do osteochondroplasty at the head neck junction. some of those patients need a little decompression of the anterior superior greater trochanter or the inferior spine. So that's important. The other thing is the correction of the head neck junction, or the neck actually can go very distal when they have femoral retroversion. Sometimes we bring that decompression more distal because they can impinge on the femoral neck or the inferior femoral neck. So thanks for inviting me. Thanks for your attention. Those are just some general thoughts about femoral osteotomy. Certainly glad to discuss any questions you have.
Oh, thank you so much, Professor Clohisy. Excellent presentation. It's a huge topic, and I don't want to bother you. So I know it's 6 a.m. in San Diego. Your Perthes case was wonderful, and it is controversial to our classic knowledge. First PAO, then proximal femoral osteotomy. You do femoral osteotomy, then minimal periacetabral osteotomy. You mentioned, but I didn't understand. Maybe I misunderstood. With CAM lesions with retroversion, young patients, you started to do femoral anteverting PAO, anteverting proximal femoral osteotomy at recent years instead of head neck junction osteoplasty. Did you mean it? At impingement patients.
Yeah. So some of those patients, especially, although I've seen it in females, but it's mostly males
Yeah.
that have severe impingement, and they have head neck offset cam deformities, but they also have, some of them with severe impingement, relative retroversion or true retroversion of the femur. So in those patients, rather than treating them with arthroscopy and just doing the cam resection, I would treat them with an open surgical dislocation. And then I do a stepwise correction of the impingement. So I start with the head neck junction. I do the head neck junction osteoplasty, just like we would usually. And sometimes that needs to be more aggressive. Sometimes, so you do the head neck junction, you take the cam lesion off. A lot of these hips, the anterior superior greater trochanter impinges. So we take down the anterior superior greater trochanter. Sometimes the inferior spine impinges. We take down that. And then we examine the hip.
Intraoperative.
And if it's still problematic in terms of the extra articular impingement or the range of motion, then I do a combined derotation of the femur. And that would be through the surgical dislocation. I just extend it distally and do a derotation like I showed you.
Yeah. So your intraoperative goal is minimal internal rotation of 30 degrees and external rotation 45 degrees at 90 degrees of flexion, isn't it? These were the volleys, or what were your goal for range of motion intraoperative, Professor Clohisy?
In that type of patient with hip impingement, yeah. Yeah, maybe, some of these hips are, they're tight muscular males. So I examine their hip dynamically. I am looking at motion for sure. With the arthrotomy and the open exposure done. Yeah, in a male, I would want at least 25, 30 degrees of interrotation and flexion.
Both papers cite 30 degrees at lower limit for your goal for impingement or other osteotomies. 30 degrees.
Yeah, goal would be 30.
Yeah. Okay. Thank you. Hakan, are there any questions? No, not yet, I think.
Not yet.
Nothing. So one more question. Sorry, Professor Clohisy.
No, that's good.
Do these patients, especially the female patients, get anxious about cosmesis? For example, they do out-towing, in-towing. Do they, when they ask about is my out-towing or in-towing will get better, for example, what do you respond to them? Will it be better or not 100%? What do you say to them?
Yeah, I think so. It depends on the case. I think with the impingement patients, Well, it depends on the case and the severity of the deformity. So the more severe the deformity, the more likely their gait is going to change. So the dysplastic with in-toeing and 50 degrees of femoral version, then I would say yes, your foot progression angle, your gait is going to improve. For a male with relative retroversion, where we're going to just do a 10-degree, 15-degree derotation, I don't suspect that to change a whole lot or for them to notice that a whole lot. For a slip with severe external rotation, then I would suggest, yes, that's going to improve.
You mean relative retroversion, 0 to 10 degrees, I think, isn't it? What's
Yeah,
your
0 to 8, I think.
0 to 8? Less than 0, it is severe retroversion.
It's true retroversion, correct.
Yeah.
Yeah. Yeah.
Thank you so much again. Thanks. Your patience. It's an excellent presentation for us. Very very little known topics in my country.
Yeah.
We do a lot of pediatric orthopedics. We do a lot of these surgeries at pediatric patients, but not at adult patients. I hope it will change from now on. Thank you so much. I hope
Yeah.
we meet in Turkey in near future. And do you have anything to say, Dr. Clohisy?
No, it's great that you guys are looking into this and wanting to learn it. It sounds like you have, all the techniques from the pediatric patient population, and it's just a matter of applying that to the adults.
Yeah, there are
I
a lot of,
don't know what hip disease in Turkey is like in terms of their
we have a lot of dysplasia patients. We still have dysplasia
Yeah.
surgeries performing to pediatric patients, and most of them is we don't see it. They are not treated, so they came to adult age patient group, and they are not treated properly.
Yeah.
Actually,
Yeah.
too many patients. Yeah,
So you can have a big impact. It's awesome.
I hope so.
Yeah. Yeah. Okay.
Okay, thank you so much. Thank you so
All right,
much
guys. You
for
take
your
care. Have a great
patience.
day.
You too. Hope you have a great meeting at San Diego and have a great time, Professor Clohisy.
Thank you very much. Thank
My
you.
best wishes to your family and to your team.
You
Okay.
too. Thank you very
Hope
much.
to
Good.
see you in near future in United States or in Turkey.
Okay. Excellent.
Bye bye.
Take care. Bye-bye.
You too.